This is EHJ Today at the ESC Annual Congress in London 2015. I'm Tom Lüscher, Editor-in-Chief of the European Heart Journal, and I'm talking about the CICD registry with Professor Michel Komajda from the Pitiè-Salpétrière in Paris and the Curie University thereat. Thank you for coming, Michel. So let us talk a little bit about the background of your registry. This is a chronic ischemic cardiovascular disease registry.
It is.
What made you set up this registry?
Two main reasons, Tom. One is that when you look at the literature, data on chronic ischemic cardiovascular disease is rather scarce, unlike acute coronary syndromes, for instance. And so it was important to get new, updated European data on this condition, which is by far the most common one that we have to deal with in our daily practice. And the second reason is that the management recommendations have considerably evolved with time. And so we thought it would be important to reassess how European patients with this condition were managed in the modern era. And if you look back at what was available in terms of European data, the latest survey conducted by the ESC was done in 2005, so 10 years ago.
Well, that's a good period to compare. What is chronic ischemic cardiovascular disease? These are patients with coronary artery disease that are stable, or do they have heart failure, or what is it?
So we decided to include a broad spectrum of patients with this condition. Namely, we had 4 different cohorts of patients. One with non-STEMI. You could argue that this is not stable, but we decided to have non-STEMI because the management is different from STEMI. Second cohort was patients who have known coronary artery disease and would undergo an elective PCI or revascularization. 3 was patients with coronary artery disease who are not planned for revascularization. And 4, we decided also to enroll patients who have peripheral artery disease because atherosclerosis, as you know, is a systemic disorder.
Right. Okay, and so it's a European study run by the ESC, central, and so how did you select the countries and the centers and so on?
So we proposed all ESC country members to participate in the pilot phase, because today we speak of the pilot phase, and 10 countries said yes. So we managed to have countries from the north, from the south, from the west and from the east to be more or less representative. And then each National Cardiac Society was contacted and they appointed the national coordinator who was responsible for the selection of centers.
And how many centers per country?
We decided to a fixed number of centers per million inhabitants in order to avoid a major imbalance in the recruitment, and also to have a balance between centers including revascularization facilities and more general hospitals without these facilities.
And these patients were followed up for a certain period?
We are speaking of the pilot phase. The plans are that the follow-up will last for 3 years.
So now we just have a sort of an overview on how it is handled today, and
yes,
what the outcome will be reported later.
Yes,
yeah.
it will.
And so what are the main results?
Well, first we could collect data on 2,500 patients over, let's say, 18 months, which I think is quite reasonable. Secondly, we observed that there are major demographic differences, in particular between patients who have been enrolled in the registry for peripheral artery disease and the coronary artery disease patients. Particularly these PAD patients are older, more comorbidities, more smoking and so on. I think the most important optimistic message is that when you look at the treatment of these patients before enrollment and when they leave the hospital, there was a significant increase in the rate of prescription of life-saving medications, including ACE inhibitors or ARBs, beta blockers, aspirin and statin, which I think is a good news, and tells us that European prescribers tend to follow the guidelines more than they did 10 years ago.
So they read what we publish, that's good.
I hope they do, and they apply what they read, which is also very, very important. And in particular, I will just mention one number. The rate of prescription of statins was 68% when these patients left the hospital, compared to 48 or 45% 10 years ago, which is a major breakthrough, I think. That's the good news.
There is some room for improvement.
Yes, there is still some room for improvement, because if you look at the proportion of patients who receive all the recommended medications, it is lower. Yeah. But nevertheless, there have been progress made for the treatment. Now, for the investigations, I think the situation remains suboptimal. First of all, we recommend in our latest guidelines published in 2013 that an echocardiography should be performed in all patients. It was made only in 70% of the patients overall, which is, there is room for improvement. Mm-hmm. And secondly, when we looked at the stress tests, those which allow us to document myocardial ischemia, it was made only in a minority of patients, which is, yeah, it's a bit of a surprise. And another surprise is that most of these patients, when they had this stress test, it was a very classical exercise test, and that modern imaging technologies, stress echo, MRI, and so on, have been done only in a minority of the patients.
Was there a difference in the economic situation of a country, the centers we're working in, and the use of these novel technologies?
Yes, there was. So it suggests that the affordability of these techniques plays a role, and in particular we looked at the difference between the patients enrolled in Central Eastern Europe compared to the rest of Europe, and the overall, as I said, the number of patients with modern technology was rather limited, but it was significantly lower in Eastern Europe.
Is it possible that many clinicians still rely on clinical signs that maybe you didn't pick up, like classical angina, and then they don't feel that it is necessary to perform such an exam?
Well, our registry honestly cannot answer this question properly, but it's very likely that since most of these patients had an history of documented coronary artery disease, probably with time physicians don't consider that it is necessary to reassess the condition of their patient, which is a mistake.
Of course, absolutely. And the echo in particular is surprising, because if once you have the machine, there is not really much cost involved, except the healthcare system is unfavorable for its use.
But nevertheless, 30% of our patients did not have an echo.
Yeah. So what are the next steps in this program? It's a pilot study, obviously, so you just want to go...
We have very ambitious goals, because since, as I said in the introduction, that data is scarce, we would like to have a huge amount of patients with a stable cardiovascular disease enrolled, and our plans are to enroll 15,000 patients. The recruitment will start next week. We have invited all the ESC members to participate in this registry. We have already 20 positive answers, which is a good sign. Very good. And I think it will give us a wealth of information on how these patients are treated. And to answer in particular one question that the size of the pilot phase cannot answer, are there geographic variations? Because it would be certainly faulty to try to make comparisons between regions with 2,500 patients, but with 15,000 patients, I think we can see if there are differences in the different geographic regions. And most importantly, you mentioned that already, we will have outcome measures, and so we can see whether outcome is linked to the way these patients are managed when they are enrolled in the trial.
So what's the take-home message for practicing cardiologists?
I think the take-home message one is, please try to apply guidelines if your resources allow it, because we have still room for improvement. And secondly, we are lacking data on, once again, the most common condition that cardiologists have to deal with. So we need absolutely to complete this long-term registry in order to communicate with our colleagues and tell us what the situation will be in 2015 and the following years.
Well, thank you very much, Michel, for sharing this data with me.